Hello again, everyone, and thank you for being here. Welcome to the One Health Lesson, One Medicine event, which has been generously sponsored by the Humanimal Trust and is done in collaboration with the World Association for Disaster and Emergency Medicine, WADEM Student Special Interest Group. My name is Dr. Bima Thapa, and I'm the Senior Promotion Intern at One Health Lesson. So I, along with my friend Lana, will be moderating the event. It's really nice to see you all here. The event is meant to be as interactive as possible. So we encourage you to type your response in the chat, or you can also unmute yourself using the hand raise button, and we'll try to address your questions. It's really nice to see you all here. I would like to remind you that this event will be recorded and posted on the One Health Lesson YouTube channel. So if you have any questions, again, you can type in the chat or let us know. And I, along with Alana, will be helping the guest speakers in moderating the chat. So don't worry if your questions are not responded promptly. We'll able to be passed to Dr. Burge or Dr. McNamara. So to introduce our speaker for today's One Medicine event, I would like to pass it to my friend Lana. Lana, over to you.
Thank you, Bima. My name is Alana. I'm speaking to you today from Maine, United States. I'm a medical student, and I am one of the co-leads of the World Association for Disaster and Emergency Medicine Student and Young Professional Interest Group. And we're very excited to be running this program in conjunction with One Health Lessons. I'd like to introduce our facilitators and educators for the next hour and a bit. First, we have Dr. Tracy McNamara. She's a veterinary pathologist and a professor of pathology at Western University of Health Sciences College of Veterinary Medicine in California. She specializes in the recognition and understanding of the diseases of captive and free-ranging wildlife, while being actively involved in the One Health movement as an advocate for a species-neutral approach to the detection of pandemic threats. Dr. McNamara is best known for identifying the West Nile virus in 1999 while working as a pathologist at the Bronx Zoo. Dr. Bill Burge is certified by the American Board of Family Medicine and currently serves with mature care in the field of geriatric medicine. He has experience in the fields of occupation medicine, urgent care, hospital medicine, and emergency medicine in rural and urban settings until he and his family moved to Maine. Since 2013, he has worked with the University of New England's College of Osteopathic Medicine to facilitate the excitement of medical students at the discovery of medicine. We are very fortunate to have you both here as educators and facilitators, and I'll give you the floor to get the program going.
Hi, thanks, Deb. Sorry for all the parentheses, by the way. I couldn't, first there was no parentheses, and it was like, why was he there? And then now there's two parentheses. I don't know what Zoom's doing. Anyway, yeah, so today we're going to be doing some breakout rooms. I'll be starting the discussion, telling you all a bit about how the breakout rooms are going to work. And then we'll reconvene and kind of finish out the discussion of the three cases. We're going to see three patients instead of just one today. And then Dr. McNamara will have a few words for us about her experiences, which I'm looking forward to. I think what I'll start with, if there's no questions, I'll start with kind of showing you the cases we'll be working with, and then we'll divide up into groups. Oh, Bima, you have something you want to say?
Oh, Dr. Burrs, I just wanted to encourage all the participants to keep the video on for a more interactive experience. Would really like you to. Yeah, back to you, Dr. Burrs.
Yeah, it's great to be able to see people's faces. You don't feel like you're just sitting alone talking to your computer. Okay, let's see, share a screen. All right, so our patients today are, like I say, there's going to be three. They all showed up the same August in the same city to three different facilities. The first one was a young female presenting with weakness, anorexia, fever, and ataxia. By day 2, she became obtunded, was rushed to the hospital, was put on intensive care. Efforts to stabilize her failed, and she died within 48 hours. Due to the unusual nature of her death, a postmortem was ordered, but results are pending. And Group 1 will be working with patient 1 and kind of working through some questions regarding her. Our second patient was just 3 days later, same city, but taken to a different facility. In this case, it was an elderly male found unresponsive, had a fever over the preceding week, generalized weakness, inappetence, vomiting, diarrhea. By the way, as you may have noticed, and is typical of these of this format, we don't reveal what the species is. So, and that's also why I kind of use terms from both. I try to mix up human and veterinary medicine with terms like anorexia and inappetence. I notice we use different terms sometimes. Anyway, vomiting diarrhea also described. On the initial exam, he developed a seizure. Within 24 hours, flaccid paralysis rendered him in need of ventilatory support. And despite the support, he died within 6 days. Postmortem results are pending, and Group 2 will be working with patient 2 and answering some questions regarding him. And then Group 3 will be working with patient 3, who presented three more days afterwards. Same city, third facility, adult male, age unknown, brought in by municipal authorities because he was erratically blocking traffic on a busy street. He appears to reside outdoors. The transport personnel describe unpredictable wandering with frequent falls across 2 or 3 lanes of traffic on a one-way street in the busy morning hours. Although non-cooperative, the patient is easy to bring in due to diminished strength and poor coordination. The patient himself is unable to provide useful history. And Group 3 will be working with patient 3. And then this, what I'm looking at right now is a link on Google. That link will take you to 3 other pages that each group individually will be working on to help you kind of answer the questions that you'll be given. But we'll be dividing up into groups here momentarily.
Sounds great. Dr. Burge, are you sharing this big Google Doc with us so that we can access these subgroups?
Yeah, and then go into the chat and drop it in there for everybody.
And I'll let you know if it works.
How's that?
It's great. And we can click on those links.
So does everybody see the link in the chat? If you click on that link, it'll take you to the root share drive, which is what I was just looking at, telling you about the 3 patients. And then that root share drive will give you 3 other links that you can click on, depending on which group you go into. But you can look at the share drive now. Everybody got the basic idea?
I think we do.
Good. Let's go ahead and divide up into groups then.
So Dr. Burge is currently getting us all situated into our breakout rooms. You will have 3 breakout rooms. Each breakout room is going to discuss one patient presentation, and we're going to have some talking points that you'll access through that bigger doc. If you're in group 1, you take patient 1, group 2, patient 2, group 3, patient 3, and they have some prompts, and we'll work together as a team from our different backgrounds to figure out what's going on with this patient, what other information do we need, and what might next steps be. And then when we're done, we'll come all back together and we will share out so that we'll all learn about our differential diagnoses and figure out what's going on with these patients. So we just are really excited and will encourage participation, cameras on if you feel so comfortable, and mine's working at 100%.
There we go.
Any questions?
Yeah, Alana, how long do we have in the breakout rooms?
Great question. We have about 10 minutes. I also encourage you take advantage of the first minute or so to do quick introductions. That way you can be on first name basis. But 10 minutes, and then Dr. Burge is going to give us a little warning, and then he'll pull us all back in together. So if you're working in the first breakout room group, edit in that doc to keep a record. That way you're prepared to share out. See you soon.
Okay, all breakout rooms will close in 60 seconds. So they should all be coming back over here pretty quickly. I want to kind of see what words of wisdom they have for us, and then kind of move through patient 3.
Just wanted to apologize for my group because we got cut off. It was a really great conversation that we were having.
I guess we'll start with group 1. Any words of wisdom? Anything you'd like to, anything you'd like to talk about?
Dr. Burge, from our group, I think it's Julia who will be presenting it. So Julia?
Okay.
So we do have some questions. The first one is about the country the patient is from, because I think it would be useful to know what is endemic in this country. I think it would help us to think of something more specific. And the previous history of the patient, everything about this patient, the background, what it has been fed, if it's an animal or human also. And I think within this previous history, also, if you could know if it's part of a vulnerable population, if it has like an immunosuppression or something in this sense. So we do have like these questions to help us focus.
Yes, lots of questions. I agree with you. There is a lot to be known. And unfortunately, we don't know about immunocompetency status. As far as location, we'll talk about why that might be important in a lot of cases. How about group two? What did y'all have any other questions or anything y'all discovered in your discussion?
It was an awesome discussion. I'm going to nominate Kimia to speak. We had people from all around the world contributing to this, so really excited about this conversation.
Okay, so what we were talking about was basically like this patient might have a very varied history. Like this cause might be ranging from infectious to like autoimmune to like different types of things. And I guess what we were like going through was we need more information on his, I guess, occupation, like what he was dealing with, like where he was for the main time of the past few days. Also, the history of his past few days, like what he had eaten, or even also other things as well. Medications also, if like he was taking any medications, and also how old the patient was, it's somehow important.
Yes, definitely, and that's one thing we kind of are reluctant to state any specific ages because it kind of gives away the species. You know, some species don't live more than a few years, and others maybe much longer. And we can say that he lived outdoors quite a bit, or spent a lot of time outdoors. But beyond that, we'll get more into your questions and everything after we find out more about patient 3. Thank you, Kimia.
So our third group, I did not nominate somebody to speak out, but would anyone from our group be interested in sharing some of our conversation?
Sure, I can go ahead. So our patient 3, so since we thought it's really acute case, we were really interested in knowing the vitals, and also we wanted to know more on if the paramedics had found any drugs on the patient or any identification as such. That would also help, and the ages that would come up with it. And so some of the differential diagnoses that we came across were quite fascinating. So we came up with drug intoxications from infectious encephalitis to HIV. Yeah, so we came up with those.
Great ideas. Let's go ahead and continue to work through patient 3, since that's the one patient we have that's still alive. So be thinking about our next step in managing patient 3 as I discuss the exam findings, or his exam findings. He was febrile at about 38.6, and he was a bit hypermetabolic at about 104, but other vitals were within normal limits. He was unable to support his own body weight on the exam table, especially on the right. Eyes were injected, mouth was dry, neck had some limited range of motion. The tone in his limbs were asymmetric, which explains why he was having a hard time righting himself, and his coordination seemed off. There's also some involuntary jerking movements to his upper extremities. So, you know, as with any facility, the arterial and venous blood draws were done really quickly. We even got some cultures ordered, but all those results are pending. Should we start antimicrobial treatments now, or should we wait? What do y'all think?
Sounds like he's decompensating really quickly. So should we throw the Hail Marys and do the antibiotics?
Anybody else have an opinion, or a strong opinion one way or the other?
It's hard to say. I feel like the temperature is high, but not the highest. And I think bacterial, I think really high fever acutely. Not sure.
I think we can control the symptoms as the Glasgow Scum scale is in 10. So I think we can control the symptoms until the cultures come. So we can start the appropriate antimicrobial treatment, because if not, we're going to give something. We still don't know if it's viral or if it's bacterial. So maybe we're giving antibiotics to a viral infection, for example. So I think we can control the symptoms. Since Ilana said, the fever is not as high as, and other symptoms are not as high. But yeah, it depends on the patient, actually. I think it's hard to say.
And someone has their hand up. Is that what is your name?
My name is Kung from Thailand.
Kung. Okay.
I think that maybe he has infection in the blood due to the blood temperature, which is the blood temperature is 126.72, but his heart rate was very fast, and his respiratory and his temperature is high too. Maybe it is a blood infection in the first stage, because any other value is normal too, and respiratory rate is 18. But in my opinion, respiratory rate is normal, but it's begin to high in the future.
Okay, so you're saying we should start antibiotics right away?
Yes.
Yeah, I agree with you. I think it's a good idea. I agree with other people that are worried about virus and other causes. You're absolutely right. It could just be intoxication with maybe I don't know, COVID or something causing a little fever. There's just no telling at this point. But what we do have, like you said, is there is the fever, and there's also the stiff neck. Did y'all see that? How his range of motion is a bit limited in the neck. So with the neurologic changes and the stiff neck, we have to assume. By the way, I think there was also a Koenig or Brzezinski test done. I think I remember seeing that somewhere. Oh, here we go. Yeah, Koenig and Brzezinski, but one was positive, one was negative. We pretty much have to treat this person as if he has meningitis until proven otherwise. Just because we don't want to hold off on antibiotics in the case of meningitis, even though it may turn out to be something else. If we hold off on antibiotics, the meningitis can easily move forward and kill them. And sometimes, cultures take 2 or 3 days to grow out. Waiting that long is a very bad idea. So what antimicrobials would y'all like to start? Anyone have ideas about how to treat meningitis? No? Okay. All right. Well, basically, what you want to cover for is things like the herpes virus, as far as a virus goes, because that is a possibility. That's about the only virus to have any treatment for. And then as far as bacteria, it's Listeria.
Strep pneumo.
So what? Strep pneumo?
Strep pneumo.
Yeah, absolutely. Great one, Sunina. Thank you. Did I pronounce that right?
Yes.
Yeah, excellent. You're right. Absolutely right. Strep pneumo is a very high likelihood. And what would you want to use to treat that?
Broad spectrum, third generation ceftriaxone.
Exactly. And ceftriaxone will also get gram negatives, and Neisseria meningitidis is a gram negative. So we could get 2 birds with 1 stone with that one, although it may be a bad term to use in a group of veterinarians.
Well, we don't know the age, but if it was a pediatric, we would want to be concerned for, E. coli, group B strep, Listeria.
Right. Listeria, I think my reference is telling me that ampicillin is the best for Listeria. So we may end up starting ampicillin, ceftriaxone, acyclovir. And my reference also tells me that vancomycin should be used, I guess just because MRSA is in the differential, even though that usually causes abscess more than a meningitis. But anyway, so we can get those antibiotics started and go ahead and get these lab results. Blood gases look pretty good. CBC looks remarkably good, which kind of argues against the bacterial infection, doesn't it? White blood cells are okay, not even a big left shift or anything. The comprehensive metabolic profile is entirely within normal limits. The liver looks good, electrolytes. The tox screen was negative, so we can't blame. Serum would be alcohol, that's negative, and fecal urinary would be other substances. Urine screen was negative. Notice I had to put kind of both in together because I didn't want to reveal the species. And we went ahead and got a CT scan. Does that make sense to everybody? Red normal for an older adult. And then we got the CSF. And now we're getting something. And for those of you that aren't real familiar with reading CSFs, I went ahead and put what you typically encounter with different types of infections. Unfortunately, there's a great deal of overlap. The biggest thing that really helps us kind of go maybe in the direction of encephalitis over meningitis is the glucose level. It being within what we'd expect, about 2/3 of the blood level, makes it a little more likely encephalitis than meningitis. But that's about all we have going for us right now as far as that's concerned. Here we got some other extra testing done. EEG showed generalized slowing in the frontal and temporal lobes. We got EMG and nerve conduction studies because of all the weakness, and they showed motor axonal loss, sensory nerve function was normal. So his motor was lost, but sensory nerve was good. Decreased recruitment on motor. Pattern consistent with polio. Gosh, anybody guess polio?
We said viral.
I guess it's close. So this is what the neurologist is calling it based on EMG nerve conduction. And then we got our postmortem results back on patient 1. Awful looking, awful, awful. Postmortem on patient 2, only microglial nodules in the medulla, cerebellum, and thalamus are abnormal. Patient 3 is alive, but we still don't have a diagnosis. So what specific microorganisms would you like to test for? Any guesses?
Polio.
Polio, yeah, that makes sense. Good. I actually checked into that. There is a polio test. One of the best ones is the stool, but it's sent off to the CDC, at least in the United States it is, and it takes about 2 or 3 weeks to come back. So we'll do that, but we'll be waiting. Anything else?
Are we asking for all these patients or just the first?
Oh, these 2 patients, we have some pathology back on them, and yeah, it would be interesting if maybe we could do a specific test on them, but I'm thinking about our live patient. We really want to know what we can do. You know, have we treated it correctly by throwing all those antibiotics and antivirals at it, or have we missed something? Any other specific microorganisms like Alana said, polio or something? Anything else?
It'd be like Japanese encephalitis.
Yeah, especially if we're in Asia, absolutely. It's a pretty common cause of encephalitis, especially in Asia.
West Nile virus in the chat and triple E.
Oh, thanks for watching the chat. Yeah, it's kind of hard to watch everything at once.
Rabies and parvovirus I see as well.
Oh, those are all excellent ideas. Excellent. And I have to research how to diagnose those. Some of them, like the rabies virus. I'd have to look into that again. But the West Nile virus, there is a test called a MAC ELISA that can be done. And that can be done of the serum and of the CSF. And in some cases, it will come back. Let's see how it comes back in this case. I think we have the result here. No, we don't. In this case, the result came back for the MAC ELISA positive. It's positive in the CSF, but not in the serum. So that means this patient has West Nile virus. And sometimes it will cause polio-like symptoms. And I'll let Dr. McNamara tell us more, since she discovered it in the United States back in 1999.
So now you have the answer. So patient number 1, our vegan patient with no history other than ataxia, was a flamingo. She was the first bird to die as part of her zoo collection in September 99. And she, flamingos, she wasn't able to hold her neck up straight. They normally hold their necks in a certain position, and she couldn't do that. And she dropped dead. Now, just to give you some context. So she's here, patient number 1, Chilean flamingo. Patients 2 and 3 were happening at the exact same time in a hospital in Queens, New York, in Flushing, Queens. And before this happened, crows have been dying in Queens, New York, for 2.5 months. And crows are big, noisy birds. The public was, screaming for a diagnosis, and they've been misdiagnosed. So we lost 2.5 months in recognizing this novel public health threat that had never before been seen in the Western Hemisphere. When the zoo birds started dying, and I had done some crow necropsies, and the lesions were the same, and I was like, oh no, whatever this was in the crows, it spilled over into this captive zoo collection, but I had no way of knowing that anything was going on in the human sector. I didn't know that until Labor Day weekend, when the New York City Department of Health announced that people were dying of an unusual form of encephalitis. CDC announced that people were dying of St. Louis encephalitis, which is a mosquito-borne virus, but we had never had a mosquito-borne outbreak in New York City, not since the 1700s. So once the flamingo died, lots of other zoo birds started dying, but 3 more weeks passed before we were able to actually achieve a diagnosis. And that's why we're talking about this today, because West Nile virus actually served as a launch pad for the One Health movement, because it illustrated quite clearly what happens when veterinary and public health and physicians do not work together. And there was a complete disconnect between the veterinary world and public health at that time. And that cost us valuable time you can't afford to waste anymore. So what I'm going to show you today is to really show the argument, all of the information that was right there before us when we did the veterinary studies. And it took several years for everything that we warned public health about after doing all the veterinary studies, for everything to be borne out in human beings as well. So again, a lot of wasted time in understanding a novel disease threat. So our first case, this was the flamingo you're looking at her brain. This is her cerebellum. Now that as medical and veterinary students, that the cerebellum is where our balance abilities are located. So the fact that this ataxic bird had massive cerebellar hemorrhage was not a surprise. It supported the clinical findings. When I did histopathology, first off, it was the worst meningoencephalitis I'd seen in all my years as a comparative pathologist. And my stomach sank when I saw this slide, because I realized when I did the necropsy, the veterinary equivalent of an autopsy, I had only been wearing a surgical mask. And that doesn't prevent tiny little viruses from getting to you. And I went home and wrote my will. The other really fascinating thing on the histopathology, this is part of the cerebellum. You can see a Purkinje cell if you go over your basic histology of the cerebellum. And this is also a Purkinje cell, but it's very shrunken and dark pink. And here's another one, shrunken and dark pink. And there isn't one here. It's just completely gone. I'm like, whoa, whatever this is, it seems to be targeting the Purkinje cells of the cerebellum. And working with, basically you saw on that calendar, I was rebuffed by the CDC for 3 weeks when I called them and suggested that there was a link between the human and the bird die-offs. And finally, in desperation, I picked up the phone and I called up the Department of Defense in the United States. I called up Fort Detrick, the U.S. Army Medical Research Institute in Infectious Diseases, and just said 3 sentences. I said, it's something new to veterinary medicine. I think it's the same thing killing people, and no one will test my samples. And they told me, you send us those samples on dry ice tonight. Because of biowarfare, are much more attuned. They were much more attuned at that time to there being something that could both, biological weapon that could hit both animals and people. Anyway, working with the Department of Defense, we developed an immunohistochemical stain. And what you're looking at, this is the cerebellum. And see this brown ribbon? This is where I was showing you, this is where the Purkinje cells are. These are the cerebellar folia. And this is an individual Purkinje cell. And everything brown is staining where viral antigen is located. So this virus, boom, it targeted the cerebellum big time. And when you're dealing with a completely unknown virus, you always have to figure out what tissues it attacks. Why? Well, from an epidemiologic point of view, if you're going to launch surveillance, you need to know what tissues you want to test to get a diagnosis. And although we had confirmed that, yes, it definitely hit the brain in some birds, but in other birds, there were many other tissues that were targeted, including the intestine, the spleen, the heart. And so before you can launch an epidemiologic investigation, you need a case definition. You need to figure out what is it we're looking for, what tests are we going to run. But to be able to do that, you really have to understand the pathogenesis of the virus. What tissues does it attack? What kind of changes does it cause? And so working with the US Army, we had all of our zoo cases, and we did immunohistochemistry on everything that had died at the zoo. And that provided us with some really very important information. So yes, it hit the brain, both the CNS and the peripheral nervous system, but also many different tissue types. And why was that important? Well, let me just talk about the CNS first. You're looking at a section of spinal cord, and these are spinal cord neurons. These are all hot with virus. Also affected the peripheral ganglia. There's a nerve. Now this one, all right, I'm a veterinary pathologist, but I read the medical literature. And as I'm reading this cross-section of a spinal cord from a kind of a gull, a kind of bird, I'm looking at the immunohistochemical staining and like, whoa, wait a minute. This is reminding me of something. And I showed this slide to the clinicians who had been working in that hospital in Flushing, Queens, that saw the initial human cases, and they almost fell off their chair because I said, call me crazy, but this is reminding me of polio. Now, what had been troubling to them as diagnosticians was that their patients presented with profound muscle weakness, and they did electromyograms confirming, something is taking out the muscles. And that had never been described in St. Louis encephalitis. So in their minds, the diagnosis of St. Louis encephalitis never matched the clinical picture they were seeing in those patients. And, it was just amazing that this was actually seen first in the birds. Then the other thing was, as I said, this virus hit many tissues. This is the stomach of the bird. This is the heart. Look at this heart. All those white areas you're seeing are areas of necrosis. I mean, if this was a person, they'd be dead. This is a cross-section of intestine, and you see all that brown? And that got me thinking, because the flamingos were in Flamingo Pond, and if they had all of this virus in their intestine, they were probably shedding it into the environment, and that raised questions about alternative modes of transmission. So what we did, you have to understand, when we did the immunohistochemical studies and coming up with a case definition and why it's so critical is because it drives the diagnostic testing. And because in humans, West Nile virus that had been described in the 1930s in West Africa, it only hit the brains of human beings. But that was not the case in birds. And CDC wanted to launch dead crow surveillance because they were easy to see, easy to find, and they wanted the public to pick up dead birds, bring them to the health department, and then they would do, at that point, they developed a PCR much later. But we said, well, based on our studies, yes, there is a wide tissue distribution of this virus, but the only tissue that's positive 100% of the time are the kidneys. And we said, if you're only going to test one tissue, maybe it shouldn't be the brain. Maybe it should be the kidneys. Better yet, if you're testing, doing a PCR test was ultimately developed, said you'd be better off if you pooled different tissues for PCR. When you do that, you reduce the risk of false negatives. Why were false negatives so important? Well, a positive PCR test for West Nile virus in a dead crow prompted spraying for mosquitoes. There was a direct public health response in when we got a positive case. And I said, if you don't take this approach, you're going to end up with false negatives, and you will not spray for mosquitoes, and you will not address the public health threat. It wasn't just crows. Public health said, we're just going to look at crows. We're like, gosh, when we did a massive sero survey at the Bronx Zoo, and we tested all 5 zoo collections that we owned in New York City. My God, it hits everything except chickens. And maybe you need to expand your surveillance beyond crows, because what really matters is just getting your first positive test. Really doesn't matter what species of bird is involved or not. And the other thing we raised, I was seeing cases in quite a few mammalian species at the Bronx Zoo. And at the time, the CDC had said that the only mosquito species involved was Culex pipiens, because that's what's in the textbooks. And Culex pipiens mosquito, they preferentially feed on birds. I'm like, yes, but I have rhinos, snow leopards, elephants, babirusa. Is it possible there might be other mosquito species involved? And why is that important? Because mosquitoes all have different biologies. Some are day feeders, some feed at dusk. And if you're spraying to take out those mosquito vectors, you need to know which ones are involved. We now know there are more than 40 species of mosquito vectors that can spread West Nile virus, but many of them would not have been affected by the spraying because they weren't flying at that time. And as I mentioned, when I looked at the immunohistochemical staining of the intestine, and this is a piece of fixed jejunum. It's formalin fixed, because at this time I'm like, that's it, I'm done. I'm not putting my nose near any fresh tissue to take a picture. Although by now I was wearing a personal protective respirator and, full personal protective equipment. But this is the mucosa of that piece of intestine. And here's part of the mucosa being sloughed through the GI tract. And many people presented with diarrhea, but that was sort of just ignored. But because this was being sloughed into the environment, I was like, whoa, I wonder, it's in the pond, they're spewing virus into Flamingo Pond. Is there any way that birds might be acquiring this infection in the absence of mosquitoes? Is there direct, oral transmission of this virus? And the other thing we noticed as veterinarians, that many hawks, eagles, owls were, they were dying in droves from West Nile virus. And if you look at the behavior of birds, what do those birds do? Those are what we call raptors. And raptors eat little passerine birds, your little sparrows and, little everything else that isn't in a raptor. So could there be not only fecal oral transmission, but could it be direct oral transmission by eating an infected bird? Could there be, because there was so much antigen in these birds, respiratory spread of West Nile virus that had in fact been documented in lab accidents? So I knew that respiratory spread was feasible. And, the whole thing was just looking at mosquito-borne spread. I'm like, well, we think there might be other means of transmission going on here. And the other thing that really raised a concern as a conservationist is I was seeing a tremendous amount of staining in the ovarian tissue and testicular tissue. So as a zoo vet, where we're always trying to breed captive endangered species, I was concerned that there might be vertical transmission from, dam to the offspring. And could that have a negative impact on our captive breeding programs? Possibly. And then it raised the issue of, what about pregnant women? If it's hitting ovarian and testicular tissue, Zika virus is spread through semen. So you just have to, with a novel virus, you just have to take off your blinders and just go where, what the pathology is telling you. And those are the studies you need to pursue. These birds were hot with virus. I mean, look at all of this brown. This is all viral particles here. And for 3 years, I urged public health to titrate the amount of virus in these birds. I said, A, I'm worried about alternative modes of transmission. B, these birds are flying germ warfare bombs. And you have veterinarians and wildlife rehabilitators handling these neurologic birds. And I was very concerned for the health and safety of people who were working with clinically neurologic birds, keeping them in cages. And most veterinarians at that time didn't have any, they didn't have access to, they didn't wear N95 masks. I mean, poodle practitioners in the New York City aren't worried about these kind of threats. So I was very concerned about a possible occupational hazard. So, because based on all of that stuff, we published our findings in spring 2000 because we wanted to get this information out before the second summer of West Nile virus. Unfortunately, the uniform response was no one believed anything we had to say. And public health maintained going into the second summer of West Nile virus, West Nile can only be spread through the bite of a mosquito. And we will only test crows and we will only test brains. A year later, the New York State Department of Health, after realizing that, some of what we said was true, because I told them many birds won't have any lesions in their brains and you're going to call them negative, but in fact, they're positive. There will be immunostaining, just no gross lesions. Then they realized, maybe we do need to start pooling tissues. And they changed their mode of diagnosis. Unfortunately, when we published our paper and in the wake of West Nile virus, when it was first announced, based on everything we were seeing on the pathology studies, we said, we need to do experimental trials. The histopathology is suggesting there may be alternative modes of transmission. The only way we're going to know for sure is if we do experimental studies. And no one would fund them. So the Bronx Zoo, that had already lost $500,000 when West Nile virus was announced and we were associated with the virus that was killing New Yorkers, gave me $25,000. I sent it to the director of the National Wildlife Health Center in Madison, Wisconsin, and they had the appropriate biosecurity to run experimental trials in crows, and they proved that there was indeed aerosol transmission as well as fecal oral transmission in the absence of mosquitoes. And that changed the epidemiology of how to pursue this virus. Very important. And unfortunately, we're seeing the same thing here these days with SARS-CoV-2 in animals. All the studies that should have been done 2 years ago, we couldn't get funding. So very little has changed since 1999 in that regard, and that's very disconcerting. 3 years later, all of a sudden, everything we had said was borne out in humans. It was now confirmed to have been in West Nile viruses in our blood supply. We were seeing it in patients with organ transplants. There was transplacental transmission. Remember my concern about pregnant women? It was being spread in breast milk. And so many veterinarians and wildlife rehabilitators had come down with West Nile virus that the CDC was now launching an environmental and occupational hazard study. But it was 3 years later. And after me pounding on tables, demanding that someone titrate the amount of virus in these birds, all of a sudden, when they finally did it, they found that there were 1 trillion to 10 trillion viral particles per milliliter of blood. And that's beyond no precedent. That's almost beyond belief. And so birds were almost 1 billion-fold more infectious with West Nile than with St. Louis encephalitis. So you have to believe what you see with your eyes. I'm looking at it. I'm looking at it in the microscope. Don't tell me these birds don't have an incredible amount of virus. Working with the Department of Defense, I had access, or, they shared with me publications because West Nile virus is it is in the biowarfare arsenal. And the Russians, that had a very active biowarfare program, had done a year-long study in primates with 10 different strains of West Nile virus. And they infected all these primates, watched them over a year, and the really disconcerting findings were whether the monkeys simply developed West Nile fever, just like people where it's like a flu-like illness and you're febrile, or full-blown West Nile virus encephalitis, At the end of the study, they concluded that whether or not you were symptomatic or not, all the monkeys developed chronic progressive neurodegenerative disease. It's like, whoa, a lot of people have been infected with West Nile virus. What does that mean for us? Because I worked at a zoo, and because we had done a massive sero survey with the Department of Defense, every animal that came into the pathology suite had known West Nile status. We knew if they had seroconverted or not. So I had that very important piece of history. The other unique thing about accredited zoos is everything that dies on the zoo gets necropsied, the animal equivalent of the autopsy. And so I systematically was evaluating all the brains as they came in. And I'm just using this one slide of a rhinoceros that had absolutely had West Nile virus confirmed with serology and neurologic. The rhino had a droopy lip, and that was a presenting sign in the horses that were dying of West Nile virus on Long Island. But when I looked at the histopathology, and this is 8 months after seroconversion, this looked like the animal had been infected just a week earlier. This is dramatic perivascular cuffing in the brain. And it's like, wow, you would not have expected to see this many months down the road. You would have expected this to have resolved. And that, raised concerns about potential viral persistence. And I showed this at the last West Nile planning meeting I attended and suggested, I also showed it. I was seeing this in birds, mammals. I showed all these slides. And I said, I don't know what's going on here, but I'm concerned if we're seeing this in both avian and mammalian species, what does that mean for humans? And the answer that was posted in the article in the Smithsonian was, people are afraid enough already as it is. No one wanted to know. No one would fund any kind of studies or set up a brain archive. And that really is what should have been done at that time. The bit about viral persistence. Remember when I said, based on the immunohistochemistry, the kidney was positive 100% of the time? Well, a CDC EIS officer in Texas started a prospective study. She followed people that had been confirmed with West Nile fever, not even encephalitis, West Nile fever, and found that 7 years later, they were still shedding live virus in their urine. And they linked that to the fact that people that had West Nile virus were now presenting with decreased renal function and urged physicians treating people for chronic kidney disease to consider looking into their West Nile virus status. So, just to sum up, everything that the veterinary studies showed us, everything that was seen in the pathology studies, ultimately was proven to also apply to humans. And there was an unfortunate delay in syncing up the veterinary findings and the human findings. And, it really is, it's a perfect example of why when you're dealing with a novel zoonotic threat, you have to work together. If you're worried about your human patients, you better be paying attention to what's going on in the animal patients as well. A virus doesn't care. The virus doesn't have those silos. The virus does its thing. And you really have to take off the blinders when you're dealing with a novel, potentially pandemic threat and just investigate everything across species. We still have a problem in the US. And, the lesson of West Nile virus was because it crossed not only species boundaries, and there was very little crosstalk across physicians and veterinarians, but it crossed agency jurisdictions and mandates. And the animals gave us 2.5 months of warning. They were waving red flags, and yet it was missed. if the crows had been appropriately diagnosed at the beginning of June, if we had put as much emphasis on getting an accurate diagnosis in the first animals to die, would we have had dead people in mid-August? And my answer is no. If we had known about it 2.5 months earlier, we would have been able to knock down the mosquito population in New York City, and I very much doubt we would have had any human deaths. So that's the clincher. It shows you may not care about animals, but boy, we better start looking for sentinels for early warning of these emerging pandemic threats. And that means we have to take a species neutral approach. If we only look at humans, and if all of our funding goes into doing surveillance in humans, that means we'll find things in humans. But that also means we're using people as sentinels, when it might be preferable to detect these looming threats in animal populations prior to spillover into human populations. But that means we're going to have to work together. Rudolf Virchow, turn of the century, had it right. He was a visionary, and he said, between animal and human medicine, there are no dividing lines, nor should there be. Since that time, we've become so specialized and so siloed that people stop taking this approach. And it really is just a mindset shift. That's, all it is, oh, I wonder what's going on in people, or I wonder what's going on in animals. We just have to get out of our traditional silos and sort of start thinking more broadly and take a more of an ecosystem approach to emerging infectious diseases. I hope I've made the case that you have to adopt a One Health approach. If we want to survive, we're going to have to perform better than we have in the past. Now, as students, I would urge all of you to start educating yourself about what's out there. A good place to go is the One Health Commission. It's one-stop shop. It tells you everything that's going on in One Health. The website is constantly updated. Go there today, have a look at it. It tells you what's going on around the world, and it's a wonderful way to be able to be informed about what's going on. The other thing is, I would urge you, both veterinary and physicians, as students, join ProMed Mail. It's free. Basically, if you want to know what disease outbreaks are taking place around the world, join ProMed Mail. You can say you just want infectious diseases. You can pick what notices you want, and you'll get emails in your box every single day telling you what's going on. For instance, I got a posting yesterday that for the first time ever, H3N8 influenza has caused illness in a child in China. H3N8 had previously only been described in dogs, horses, and seals, and it has now jumped species. As of today, there's a huge 57 horses over the course of a week have died in Colorado, and as of today, they're saying it is H3N8 influenza. The flu viruses are things we must be watching very, very closely. And, we can't afford to have a repeat of the 1918 pandemic flu that killed between 50 and 100 million people. We must be looking across species. ProMed Mail is in lots of languages, and I urge you to add that to your email. Just join up. The other thing I would really suggest you do, especially for, because this is an international audience, when we had the H1N1 scare, when everybody was terrified that we were all going to die of, a pandemic flu strain, there basically was a treaty where all countries agreed to join the Global Health Security Agenda. And that was to make sure all countries could detect and respond to pandemic threats. As part of that, we've spent like $1 billion on this. Countries would invite experts to come in and evaluate their public health system, their veterinary system, their wildlife system, so they could start building One Health programs and see where the gaps were. And these reports are called joint external evaluations. So if you just Google Global Health Security Agenda, JEE reports. You'll see what's going on in your own country. You can see what things were, these are weaknesses or these are strengths, and this is what they're working on. And it may be a way for you to get more involved with One Health in your very own country. The same thing goes for veterinarians internationally. The OIE, the World Animal, the Office International des Epizooties, or the World Animal Health Association, puts out performance of veterinary services evaluation reports. And these, the joint external evaluations, they're just like 3 days. The performance of vet services reports, these are two-week investigations. They're extremely thorough and excellent reports. Unfortunately, you'll see when you read these reports that human medicine is light years ahead of the veterinary sector. And that's going to have to change if we want to get a handle on pandemic zoonotic threats. That's the challenge before us. And these are all countries that have had the performance of veterinary services reports posted. They have to release them. They're not available and publicly available unless the country agrees. But there is a wealth of information out there for you. Like I said, the One Health Commission, ProMed Mail, Global Health Security Agenda, Joint External Evaluations, and the OIE Performance of Vet Services reports. Educate yourself within your own country. Find out what the politicians are doing, what legislation is in place to address the inequities across the veterinary sector and the human health sector. What needs to change? How can we make this system work? We haven't gotten ahead of any of these pandemic threats. We've missed every single time we've messed it up. And now we have COVID. This is like our last wake-up call. And it's time to get serious about One Health and operationalize it across the world. And I very much hope you guys will be part of that. And I hope this presentation convinced you of the need to do so. And I'm thrilled so many of you joined today. So I'm going to stop sharing and then we can move on to questions.
Thank you so much, Dr. McNamara, for speaking and sharing your experiences with all of us. I see there is a hand raised. I believe it's Kung. If you had a question.
Excuse me, does this have a slide presentation after ending of this work?
Do you want to write it in the chat box?
Yeah. Okay.
Thank you.
While we're waiting for that, for those of you in the United States, Dr. Thompson and I are working with a group of subject matter experts, and we are attempting to enact legislation that would level the playing field across agencies. Because although there's been talk about One Health for 22 years, and although the US has invested heavily overseas in Africa and Asia, we haven't invested a dime in the United States. And the public health agencies still have all the money. And then we have the USDA that does agricultural species. And then we have like a few pennies for wildlife. And given that all of these diseases have emerged in wild populations, that should make everybody go, whoa, how are we ever going to find anything if we don't somehow strengthen our ability to do wildlife disease surveillance? And that is global. That's global. No one owns wildlife. They don't have any trade implications. They're not going to, generate funds. So nobody bothers to fund wildlife disease surveillance. And that is our weakest link in the chain of biosurveillance and our greatest challenge in being able to detect novel pandemic threats and spillover events. But the money still hasn't changed. It's still human health gets the huge, forget the One Health Venn diagram. There's three different circles: human health, ag, wildlife, and then there's nothing for anything else. And when you think about, like the H3N8, the canine influenza, we've had so many outbreaks right here in Southern California this year in dogs. You realize there was no surveillance of dogs, no surveillance of cats, no surveillance of animal in shelters. We had a huge outbreak, the first flu outbreak in cats in 2016 in a crowded animal shelter in New York City. and it was instant replay of West Nile virus. In 99, CDC said we don't do flamingos. In 2016, both CDC and USDA said we don't do cats. The problem with that was by the time a diagnosis was achieved, and that was only after a private foundation that supported shelters paid over $1 million for quarantine and PPE, over 300 families had already adopted cats out of that shelter. 300 families in the greater metropolitan area, because shelters push animals out as fast as they can. And I flew to Washington, D.C., and I said, guys, enough already. How many wake-up calls do you need? You dodged a bullet. But for the grace of God, if this virus had been more virulent, because it did chump species, the attending veterinarian got sick. It's like, you had nothing to do with this not being the world pandemic. I want to know what you're going to do about the next time. And we still haven't solved that issue. So, it's easy to talk One Health. We need to start taking a more holistic approach to funding the different components of One Health so we can detect these things and use Sentinel. A Sentinel can be any species. It doesn't have to be. There are no cows walking down Fifth Avenue. The USDA is not going to help us if there is a biological threat in New York City. But there are plenty of dogs, cats, zoo animals. Look at COVID, look at SARS-CoV-2 and zoo animals. Only now, 2 years later, the USDA is now just starting to do serosurveys of zoo animals. I'm like, well, we did that within 2 weeks of West Nile virus. Why did it have to take 2 years for you guys to do it for SARS-CoV-2? It's, they talk about lessons learned of West Nile. I think the world needs some remedial education, because from where I'm standing, no lessons have actually been learned. So,
Tracy,
yes.
Did you see that article in Nature just a few days ago about climate change increasing cross-species viral transmission risk?
Oh, God, yes. I mean, look, what can I tell you? I knew the Assistant Secretary for Preparedness and Response, Bob Kadlec, and I spoke with him in 2017. And this was a guy in charge of protecting the health of the United States. And I was like, Bob, come on, enough. When are we going to do species neutral biosurveillance? And he said, I agree with you 1,000%. But you need to recognize the system is broken, broken, broken. Wow. When the man in that position says that to you, that day I ordered a year's worth of non-perishable food supplies, cases and cases of N95 masks, and I actually bought, an $800 papper. So, the system is broken. It still hasn't been fixed. And I really think as young students out there, you guys have to become advocates for change. The status quo is going to get us all killed. And you guys have to start screaming for change and push for actual adoption of One Health. Otherwise, we're goners.
David, do you have a question?
Yes, thank you. And to add to that, it's not just talking in our silos, it's talking amongst us and synergizing our strengths. And that's exactly why this One Medicine event exists. I mean, look around you on this virtual platform that we're at right now. There are people from all around the world, so many different cultures, so many different disciplined backgrounds. We're coming together to learn, right? To exchange knowledge and to think in a manner that we can work together and get some real changes done. Just like what Dr. McNamara and I, what she mentioned early is that she and I have been working to help change legislation, change policies in the United States. But this can be done anywhere you are on this planet, as long as you stay as creative as possible and start to network. Some of us, depending on where we are in this country, in this world, we have bigger mountains to climb when it comes to changing legislation and changing policies, but never say it's impossible. I know that we are running short on time, so I do want to make sure everybody is aware that we have a YouTube channel. This will be eventually posted on our YouTube channel. There is also a post-event survey that BMO will put in the chat box shortly. So if you do want a certificate of attendance and participation, then fill out that survey. With the feedback form that was just put in the chat box. It has been such a pleasure and an honor to hear from Dr. Burge and Dr. McNamara. Thank you so much to the Humanimal Trust for sponsoring this event. And thank you, WADEM, for partnering with us today at One Health Lessons to make this a reality. It's been absolutely incredible. And I've been getting wonderful feedback in the chat box ever since the start of this program. So please rest assured that what you have said today has made a substantial difference in lives around the world. And I wish you all the best, and connect with us on LinkedIn, Instagram, YouTube, Facebook, Twitter. We're all over those social media posts. And our next One Medicine event should take place in about 3 to 4 months. So just stay on top of those social media posts and you will see the announcements. I just want to respect everybody's time. Thank you again for staying on with us for an hour and a half.
If I could say just one more thing, one last thing.
Please.
The reason we know about West Nile virus is because I was a veterinarian working in a zoo who was accustomed to working at a frontier of veterinary medicine. When I was doing this work, there were only 7 zoos in the United States that have full-time pathologists on staff. So I was discovering new things all the time. So I think a lot of us as diagnosticians, certainly my regular veterinary pathology friends, they just look for what's known. And I was like, at the end of every necropsy, I would just say, but what if this is something new? And it's just a tiny shift in perspective. Have the humility to recognize we don't know everything. What if we're wrong? What if it is something new? But I'll guarantee you, you will never discover something new unless you make that mindset change and keep yourself open to, well, let's think of all the possibilities. And Louis Pasteur said, fortune favors the prepared mind. So I'd leave you all with that. And, you know, who knows? You guys may discover the next biggie. It's just an approach.
Dr. McNamara, whoever taught you these skills has made such a difference in this world. And that's what you're doing today, speaking with all of these future leaders in health, regardless of what health we're talking about, because now we're talking about One Health, right? And I'm sure people are going to turn off the computer soon and think, wow, did I just watch that? Right? Wow, was I just in a room with people from around the world?
Yeah.
Wow, how am I going to change? How am I going to spread this message, right? So thank you, Alana. Thank you, Bima, for organizing this. Well done. Thank you, Dr. McNamara. Thank you, Dr. Burge. And thank you again, Humanimal Trust. Onwards and upwards. See you next time.